Echocardiography is the sheet anchor of diagnosis of hypertrophic cardiomyopathy. This picture summarizes several features of hypertrophic cardiomyopathy seen on echocardiogram. This parasternal long axis view shows the grossly hypertrophied interventricular septum and also the speckled appearance of the myocardium in hypertrophic cardiomyopathy. Here you can see a mitral regurgitation jet, which is rather common in hypertrophic obstructive variety of HCM. Left atrium is dilated due to the increased left ventricular and diastolic pressure. And this is showing the left ventricular outflow tract gradient in hypertrophic obstructive cardiomyopathy. Here the gradient is seen as 31 millimeters of mercury. The gradient is dynamic in nature so that it can increase and decrease over time. It is preload determined, and there are maneuvers which can be used to increase and decrease the gradient in hypertrophic obstructive cardiomyopathy that can be used even in the echocardiography room, like squatting, hand grip exercise, and during the procedure you can check the variation or the dynamic gradient in LV outflow obstruction of hypertrophic obstructive cardiomyopathy. This is an important question for cardiology students. Brock-and-Braunwald sign on cardiac catheterization. This is during a sinus beat, left ventricular tracing and aortic tracing, pressure tracings. And what happens during an ectopic beat? The pressure is lower because it's premature and left ventricle did not have much time to fill, and the gradient is also lesser. This is the gradient. Gradient is lesser during the ectopic beat. After that there is a pause. So left ventricle gets longer time to fill, and during this excitation all of the calcium released is not used. So there is some extra calcium available for increasing the inotropy during the post-ectopic beat. And post-ectopic beat also has higher inotropy because of the increased filling and diastolic volume. What happens is that when there is increased inotropy, there is increase in the left ventricular outflow tract obstruction. So that produces a higher gradient. This is the higher gradient in post-ectopic beat, and the left ventricular systolic pressure is much higher. Aortic pressure does not increase so much. That's because of increase in obstruction. This is the classical Brock-and-Braunwald sign during cardiac catheterization in hypertrophic obstructive cardiomyopathy. Ectopics can occur spontaneously or can be induced. It is an autosomal dominant disorder with variable penetrance, with either a defect in sarcomeric protein genes which encode for myosin heavy chain, actin or tropomyosin, or due to abnormal myocardial calcium kinetics which increase intracellular calcium, causing hypertrophy and cellular disarray. MYH7 mutation in the gene which encodes for beta-myosin heavy chain, located on chromosome 14, is found in about 15 to 25% of cases of HCM. MYBPC3, which encodes for cardiac myosin binding protein C, is abnormal in another 15 to 25% cases. Besides these, several other mutations have been described, some of which are available for commercial testing. There are several phenocopies of HCM caused by other disorders like Barth syndrome, Danon syndrome, Pompe's disease, Fabry's disease, Friedreich's ataxia, and Noonan syndrome. Genetic markers for several of these disorders are also available commercially. Sigmoidal HCM, which is about 40 to 50%, has about 10% positivity for myofilament gene. Reverse curve HCM occurs in 30 to 40% cases and has a myofilament gene in 80% of them. Apical HCM and neutral HCM with symmetric hypertrophy contributes 10% each and has 30 to 40% positivity of myofilament gene. The most common symptom of hypertrophic cardiomyopathy is dyspnea, which occurs in 90% of cases and is due to elevated left ventricular diastolic pressures as a consequence of the diastolic dysfunction. Angina is another common symptom due to the hypertrophy, which causes a coronary supply-demand mismatch. Symptoms of HCM include syncope or near syncope, which could be precipitated by exertion, hypovolemia, rapid standing, Valsalva maneuver, diuretics, vasodilators, or arrhythmia. Palpitation can be felt if there are arrhythmias. The carotid pulse is jerky and may have dual peaks, but the second peak is often appreciated only in a pulse tracing rather than on palpation because it is somewhat rounded. Jugular venous pulse may show a prominent A wave. Double or triple apical impulses can be felt in HCM. In case of triple impulse, it is one diastolic due to forceful atrial contraction and two systolic impulses due to mid-systolic obstruction. Paradoxical splitting of second heart sound can occur due to the left ventricular outflow tract obstruction. A third heart sound occurs when the left ventricle decompensates in late stages of HCM. A prominent fourth heart sound is usual in HCM due to the diastolic dysfunction which causes forceful atrial contraction. Dynamic oscillatory features are important in the diagnosis of HCM. The systolic ejection murmur increases with a decreased preload as in volume depletion, nitrate therapy, or standing, or a decreased afterload with vasodilators. The murmur decreases with an increase in preload or afterload, isometric hand grip. The post-ectopic increase in murmur is a hallmark of hypertrophic obstructive cardiomyopathy, which differentiates it clinically from mitral valve prolapse. ECG changes in HCM. ST T-wave abnormalities are common, with ST segment depression and T-wave inversion predominating. Left ventricular hypertrophy, left atrial enlargement, QRS axis deviation, left more than right, conduction abnormalities like increased PR interval, and bundle branch block may be noted. Atrial fibrillation, if present, indicates poor prognosis as hemodynamic decompensation occurs due to loss of atrial booster action, which is vital for the filling of a hypertrophied left ventricle with severe diastolic dysfunction. Important echocardiographic features include mitral regurgitation and left ventricular outflow tract obstruction. The ejection fraction is high to normal except in late decompensated stage. Small left ventricular cavity and left atrial enlargement are other features. Septal thickness is often 4 to 6 mm more than normal. Asymmetric septal hypertrophy with absolute thickness more than 15 mm, septal to posterior wall ratio more than 1.3 in normotensives and more than 1.5 in hypertensives are some of the features. Rarely, normal septal thickness can occur in genotype positive cases, especially in cardiac troponin T mutations. Normal echo earlier in life can occur in cardiac myosin binding protein C mutation, which mandates repeat echo evaluation after 5 years. Apical hypertrophy can produce an ace of spades configuration of the left ventricular cavity. While assessing the severity of HCM, maximal wall thickness in multiple segments, length of septal hypertrophy, extension to apical segments, and involvement of papillary muscles, anterior displacement or direct insertion into mitral valve have all to be looked into. Systolic anterior movement of mitral valve occurs in 30 to 60% cases, but it is not specific. SAM causes LVOTO, increased ejection time, and a decreased stroke volume, as well as mitral regurgitation due to poor cooptation of the leaflets. Severity of SAM can be quantified by SAM septal contact time. In mild cases, it is less than 10%, and in severe cases, it is more than 30% of the systole. Peak gradient more than 30 mm of mercury predicts a CD in HCM, though the gradients may be much higher in some cases. LVOTO is due to septal hypertrophy, SAM, and anterior displacement of mitral valve apparatus. Mid-cavitary obstruction in HCM is associated with apical aneurysm, systemic embolism, and arrhythmias. Cases are on record in which ablation of the fourth septal artery has been done to ameliorate the obstruction in mid-cavitary obstruction. Dynamic gradient occurs in 25 to 30% and depends on blood volume or contractile state. Dynamic gradient may be sought by glyceryl trinitrate, Valsalva maneuver, standing position, or even symptom-limited exercise. Obstruction may occur during recovery, and post-exercise monitoring of gradient is mandatory. Distal or apical hypertrophy may be missed and is best estimated on sequential short-axis views. Wall thickness may be normal in children and adolescents. Cardiac troponin T mutations, as well as in end-stage HCM with dilated LV. Oblique cut or foreshortened views and sigmoid septum in elderly can cause false positive diagnosis of HCM. Thin posterior wall in inferior wall myocardial infarction causing abnormal septal to posterior wall ratio can also cause suspicion of ASH. LVOT gradients in hyperdynamic states may also be mistook for LVOT obstruction in HCM. Differential diagnosis is not just by echo, but there is vital role for history and clinical examination. Hypertensive heart disease is an important differential diagnosis, but SAM is rare in this situation and there is evidence of greater diastolic dysfunction in HCM. Athlete's heart is another entity with hypertrophy which may be confused with HCM. Normal or supernormal tissue Doppler velocities in athlete's heart contrast with impaired velocities in HCM. LV cavity dilatation is seen in athlete's heart. Cardiac amyloid is manifested with thickened interatrial septum, increased myocardial echogenicity, and thickening of wall leaflets. Cardiac cath has a limited role in the diagnosis of HCM in this era of echocardiography. Degree of outflow obstruction can be documented along with the classical Brockenbrough-Braunwald-Morrow sign. The sign is an increased LVOT gradient after a ventricular premature complex. Evaluation of diastolic characteristics of LV and LV and coronary anatomy evaluation are other diagnostic uses of cath in HCM. The role of cath nowadays is mostly for septal ablation. Holter monitoring is useful to document non-sustained atrial or ventricular arrhythmias which may not be obvious clinically. Delayed enhancement on contrast-enhanced MRI is useful in documenting fibrosis in HCM, which is a predictor of systolic dysfunction and has a relation to heart failure symptoms.